Good morning. So nice to see you all in person again. So I'm going to talk about peripancreatic fluid collections and an approach that hopefully applies to both interventionalists and non-interventionalists. So a relatively typical case, middle-aged guy had pancreatitis. He kind of smoldered for a few weeks, including an ICU stay, and he just didn't quite get better. He couldn't really eat all that well. And he has kind of this, football sitting in his belly, compressing his stomach there. And so the answer is what to do with that. And so as you see this video of the endoscopic treatment, we're going to talk about before you get to this point, during this point, and after this point, what are the things that you should do or don't do, try to avoid, try to put you in the thought processes that we go through as we're asked to manage these. So this is kind of the catch your attention video, but we want to think about it more, strategically outside of just the intervention. The intervention itself is all of 2 minutes, providing the cyst gastrostomy with current technology. But what you do before and after, when you decide to pull the trigger, when do you involve colleagues, these are some of the do's and don'ts that we're going to want to talk about. So you can see relatively quickly, you get a controlled hole in the stomach with lumen apposition and immediate drainage that's very satisfying. And what you do after that point is, kind of dealer's choice. Dilate the tract, don't dilate the tract, go in there and start digging around, etc. In this case, we're electing to dilate, and so you'll see that stent lumen open to its maximum, and that allows you to peek inside. This one happens to be a fluid collection that has more fluid than necrosis. It's probably accurately termed a pseudocyst, although there is some necrosum there. Many of these, even when they're called pseudocysts, often have more necrosis than the CT suggests. And so you see the nice, mature cavity that we're looking into for some reason. And all right. Okay, so when you find a fluid collection, you want to think about a differential diagnosis. Often it's obvious, and sometimes it's not. The times that it's obvious are relatively easy, but it behooves you to think of the less obvious things. Loculated ascites, hematomas, congenital duplication cysts, other organ cysts, the occasional diverticulum that's filled with fluid and gets called as a pseudocyst on imaging. The things that we're really looking to drain are generally pancreatitis related and postoperative related fluid collections. So the key point is make sure you're dealing with the appropriate target. Don't drain a cystic neoplasm. It stings when you do that. Once in fellowship, I was involved in a case like that, and so far, no others. But also, outside of cystic neoplasm, loculated ascites, that'll be a potential problem, or ascites that isn't recognized, kidney cysts, etc. So if you're not sure, doubt the diagnosis. Just because the CT scan says pseudocyst doesn't mean that that's what it is. So particularly a cyst without a clear history of pancreatitis that kind of pops up out of nowhere doesn't necessarily mean that's right to EUS and drainage. And judicious occasional use of FNA is okay to figure out what's going on. I say judicious because you want to be careful if it is a pseudocyst. If you stick a needle in and you contaminate it occasionally, if you don't provide drainage, you can get infection. And it's okay to pause and not immediately pull the trigger and phone a friend. And I can be that friend if you need it. So, just call for help. It's okay. So basic stuff that you kind of want to think about. Assessment of severity and triage, hydration, particularly within the first 2 to 3 days. Figuring out at that point and down the line, if the cause isn't obvious, what's the cause. involving surgery and interventional and medical colleagues, appropriate use of antibiotics when infection, particularly later in the course, is suspected. And nutrition is very, very important. So it comes to key point number 2. Do think about nutrition. Don't use TPN. And if you're thinking about using TPN, don't use TPN. There's pretty good data that causes more harm than good. There's the very rare patient that needs TPN for pancreatitis. They have like abdominal compartment syndrome or dead bowel, or, these are very, very few and far between. If someone's unable to tolerate PO, think very early of an NJ or even an NG tube. It's unclear that enteral feeds are necessarily better, but most of us kind of push to try to get an NJ in either endoscopically or fluoroscopically. Trickle feeds are better than nothing, even just a little bit of bowel stimulation with enteral feeds, and it's certainly better than TPN. And if it's likely that someone is going to be sick for a long time and unable to tolerate oral alimentation, particularly if an NJ tube is going to be there for a period of a couple weeks, a GJ tube is a perfectly valid means of providing nutrition. Once their course is completed in a few months, it comes out, no harm, no foul. Moving on, it's important to think in phases. In the early phase, people are sick and SIRSy and they look septic, but they may not be infected. After a few weeks, infections tend to be more common, and that's when we start to recognize evolution after a few weeks of these peripancreatic fluid collections. And really the management and the severity of peripancreatic fluid collections and these kind of pancreatic complications determine the course. So it behooves us to be familiar with the Atlanta classification. Early on, the pancreatitis is either necrotic or not necrotic, and there's either, if there is fluid collections, they're acute pancreatic or pancreatic fluid collections, or if there's necrosis present, an acute necrotic collection. So it's incorrect to talk of things or use terms such as phlegmons or pancreatic abscesses or things like this. At this point, either of those can be infected or non-infected. At this stage, it's generally uncommon to have infection, but it's not unheard of. And then after time, generally a few weeks, the acute fluid collection develops into a pseudocyst, and the acute necrotic collection develops into a walled-off necrosis. Here's a patient that we've been taking care of just to give you a real-time evolution. Came in with a biliary pancreatitis and a clearly extensive acute necrotic collection involving multiple zones of the pancreas into the retroperitoneum, into the pericollicular. But you can see here that all that fuzz in the middle is poorly defined, and the pancreas itself is kind of doing okay, but there's a lot of peripancreatic necrosis. This is not a time to drain this person. You would regret it most likely if you put an endoscopic drain in the absence of a mature wall. Another week goes by and you can start to see a little bit more maturation. There's, you can trace out a border, but not all the way across. Some areas are still fairly ill-defined. And at this point, if you act, you may think you have something that you can drain, but sometimes they'll end up with essentially a free perforation because the area that you're draining is not well contained. And then another week goes by and it's much more contained, and we look at it very closely with our surgery colleagues and our radiology colleagues, and okay, we're ready to pull the trigger, we move forward. So timing is important. Don't perform transmural drainage too early. Review the images yourself. Look for maturity of capsule. Look for a blood vessel. Look for an adjacent structure. A gallbladder looks a lot like a pseudocyst sometimes, so kind of make sure you know what you're looking at. Consult with surgery and IR. Don't act on your own as an island. This is a multidisciplinary disorder. As a rule of thumb, 4 weeks is a good amount of time, but you can be earlier if it's mature and there's a suspicion of infection. That's the main reason to drain earlier than 4 weeks, if someone's symptomatic and infected. If they're not infected, you can manage generally with NJ tubes and supportive care until the 4-week mark hits. So when do you kind of intervene? Infected necrosis, obstruction of something. Probably the most common thing is they're just not getting better, and you need to kind of do something. So continuing that, recognize not just when to do it, but also when to wait. Don't drain something that's immature. Don't drain something that may become a bleeding complication. So looking for vessels that are running through the necrotic course and a pseudoaneurysm. If there's blood products within the collection, look for a pseudoaneurysm, and they may need embolization beforehand. Small asymptomatic pseudocysts or necrotic collections generally don't need to be drained. You can just kind of watch them. And again, kind of know the difference between necrosis and a pseudocyst. So we talked about transmural drainage a lot, but transpapillary drainage is still cool when you need to. The times that it probably is most common is trauma. Someone gets whacked in the belly and they have right across the spine in the middle of the pancreas body an injury to the duct, and those are often stentable. If they have a postoperative leak, kind of someone had a tail resection and just a blowout of the tail, a stent often works fairly well. If there's chronic pancreatitis with an associated stricture and a duct blowout, and pancreatic ascites. But the PD stents don't do all that well when there's a large necrotic cavity or pseudocyst. And it's okay to kind of consider to do both, tailored to when you need to do it. There is a role for percutaneous drainage, and it's important to discuss this in a multidisciplinary setting. In general, you want to try to do transmural drainage just because of the morbidity and issues of pancreatic cutaneous fistulas and managing drains, etc. But sometimes you have to. If someone's infected persistently despite your best efforts endoscopically, or there's areas that you can't access, maybe a large necrosum extending into the paracolic gutters is a common reason. And like I said, it's okay to do both. The step-up approach is what's commonly used. So you've decided you're going to kind of do it. You should, when you do it or when your colleague does it, you should be staring at this thing much longer than you actually deploy your whatever device you choose to drain it. The actual deployment of a lumen-opposing metal stent is like a 30-second to 90-second endeavor, but you should be looking for landmarks, vasculature, where you're going to strategize that the stent ends up. If you're going from the duodenal bulb, it would be a bad day if you deployed through a compressed bile duct. Maybe if it looks like you need to do that, do an ERCP and protect the duct with a stent so that you can visualize it on the US. Look for a good window, a thinner wall, no vessels, a good landing zone of anechoic fluid, positioned in a way so that if you need to do necrosectomy, you don't have to kind of, wrestle yourself to get into the cavity. You want to be a little bit away from the GE junction and esophagus, a little bit away from the pylorus, and an adequate landing zone. There are wider saddle stents for thicker walls, and occasionally you may have to go back to the old style of pigtails over wire. Steve's favorite way of doing it. Practice proper technique and practice proper technique, meaning that you should do things well, but also do it repeatedly in an animal model or, in our hands-on station. We have a fine expert here, Dr. Sethi, who will help you to kind of get a handle of these in the hands-on. Take advantage of that so that it's relatively ingrained how to deploy these things. It's not an FNA, it's a controlled cautery-enhanced hole. And so it should be slow, let the cautery do the work, or the electrosurgical energy do the work. You want to make sure you're landing properly. You want to make sure each flange independently properly deploys. These are more technical things, but kind of key points to keep in mind. After the lens is done, you got to do something. Are you going to dilate it? Are you going to leave it alone? Are you going to put a pigtail in? Are you going to irrigate with hydrogen peroxide? Are you going to put a nasocystic catheter in? Are you going to put multiple stents in? These are things that isn't really standardized, but you should have an idea ahead of time. Complications happen. The most common probably is bleeding, or more important is probably bleeding, and then stent occlusion with necrosum is important as well. So these are relatively easy procedures, but it's stuff that can happen down the line, particularly bleeding with the metal stents. And so you need to have a plan afterwards. The bleeding tends to be more common for longer indwell time. So you want to have a plan to get the metal stent out in about a month or so. and see if you need to replace it with sort of indefinite pigtail stents or pigtails until you're going to complete your necrosectomy. The point is to just have a plan depending on your imaging. Necrosectomy itself, once you kind of get in there, I don't think anyone enjoys it. It's kind of tedious. There are, starting to be dedicated devices on the market that, were going to be marketed for this type of stuff, but everyone has their favorite tools and techniques. Allocate enough time. I usually say I'm going to do as much as I can in an hour and then we're done, and then come back. What you don't want to do is dig around in there and find that there's the splenic artery running around that you didn't know about and you started to dig into the wall. So looking at the imaging is super key. And you don't have to finish it in one session. I think most of the time you can do what you need to, put a pigtail, give it some more time. And in fact, with time, these things probably soften up. So that's pretty much it, kind of quick and dirty, hopefully put things in perspective. Thanks very much.